I was wrong. So we heard a very nice talk from Louis, and so it makes my job a bit easier in a sense that I will not have to talk about different solutions there, and he already mentioned a bit about how we should give fluids. So I will repeat some of these concepts. But the very first thing that we have to remember, I think everything that we do in terms of hemodynamics, whether it is fluids or whether it is inotropes, and to be fair, any strategy that we have in our patients is that we treat syndromes, and syndromes, they have very different timelines, and our target should be different also according to where we are. So if I'm taking a patient from the emergency department that is very hypotensive, to be honest, I will not be doing very fine-tuning about giving 200 mL or 250 mL of fluids. Sometimes there, the answer is just to start to give some fluids. Now, hopefully after a while we'll be able to stabilize that patient, and maybe we can start to think about what we're going to do next. So I think it is the natural evolution of our patients that inevitably, when they come with shock, and certainly with septic shock, we will increase the positive fluid balance at the beginning. I don't think there's anything wrong with that in the initial phase. But we need to be able to understand really where we are, because as I will show you later, the effect of fluid sometimes is not permanent, and therefore what we give needs to give us some benefit, and potentially it can always give us some risks, or there will be some price to pay. So we need to be very precise always in identifying why we are giving fluids in that moment. So Lou was saying before that he gives fluid just as a bolus. I suspect he just doesn't wake up in the morning and gives a bolus of fluid. He will give fluids if he thinks that there is a problem with the perfusion of the patients, or if we think that by giving fluids we will be able to improve cardiac output and therefore to improve the perfusion. So this question to me should be a question that we should repeat as a mantra every time we approach our patient and we think, is the perfusion okay and can fluids help? Because if we don't do that, really we can escalate this line and just make the patient positive and positive and positive and so on. And at some point during the phase of the intensive care stay of our patients, we also have to realize that all this edema, all these fluids that we're giving, at some point we will have to try to get rid of them. And so the important question is, it's also the opposite. Start to realize, when can I start to get rid of fluids? So really it is crucial, I think, always to use our clinical examination, touching the patient, the skin, the temperature, the mottling, whether the lactate is elevated or not. Let's always ask that question, is the perfusion okay? Because it is only if we believe that we are in that phase where the oxygen delivery and the oxygen demand is actually dependent on the oxygen delivery, that our intervention by increasing oxygen delivery, by increasing cardiac output, can bring some benefits. And that usually is a very short time window that we have in our patient, probably the first 6, 24, 48 hours maximum. Treating hypotension always with fluids later on just because the patient is fluid responsive not always is the right thing to do. And I will show you that later, maybe what we can do in some of these patients. So why do we give fluids, and what is really the effect that we try to elicitate in the circulation when we give fluids? Well, Guyton has told us that if we imagine our blood volume distributed into the blood vessels, and I imagine my blood vessels as an elastic band, there will be some blood that is just filling the compartment without creating any stress on the walls. Then part of this blood will start to generate some stress on the walls, and this stress will generate a pressure which we can call mean systemic filling pressure. Now, if this is my heart and this is the backwards pressure from the heart, which is basically the right atrial pressure of the CVP, in order to have venous return or in order to have flow, as in any hydraulic system, not just in the human being, not just in the cardiovascular system, I will need to have a gradient between this pressure here and this pressure here. So it goes without saying that when I give fluids, what I'm trying to do, I'm trying to increase the stress volume here. By increasing the stress volume, I'm trying to increase this pressure here. But a good heart will try actually to keep the CVP as low as possible. So a good heart, like the one of all of us, I hope, in this room, should try to keep the CVP maybe between 0 and 3 in a state of health. So all those concepts about trying to raise the CVP, well, that was never our goal. Our goal was to try to increase the pressure here, but measuring this pressure is not really possible at the bedside. You would have to measure the pressure on a patient in cardiac arrest. You can imagine this is not something we want to do in all of our patients. We have surrogates ways to look at this. What we can do nowadays, though, we can simply look at what happened in terms of venous return and cardiac output, and maybe looking at the same time what happened to the CVP. But a very important concept is the heart is trying to keep the CVP as low as possible. My goal is not to raise the CVP, my goal is to raise the volume here, and that will increase the mean systemic filling pressure. The knock-on effect may be an increase in the CVP, but it's not my main goal. And that is why when we made this consensus of the European Society of Intensive Care Medicine, and we wanted to give some messages about when to start fluid resuscitation and whether we should use a CVP or not, we actually say we shouldn't really be based on CVP values, absolute values of the CVP. But it is true that in the majority of shock states, if we think about fluids, probably we should start about giving some fluids, especially if the CVP and maybe the wedge pressure, but it's very unlikely that you're going to measure that, they are very low. If they are very low, at least they are telling us that the heart is pumping all the venous return forward. So at least they are telling us, you can try, you're in a situation in which the risk-benefit profile is probably a good one to try to give some fluids. But on the other hand, absolute values of the CVP, they just do not make sense to be targeted. We tested this approach to see if what really happens in terms of responders and non-responders is a difference in the gradient of the venous return. And indeed what happened is this: if I give a fluid challenge and I classify patients between responders and non-responders, what happens is that the responders are the ones that are able to increase the gradient between the mean systemic filling pressure and the CVP. So that means that the mean systemic filling pressure has increased to an extent that is higher than the CVP. On the other hand, the non-responders, despite increasing the mean systemic filling pressure, so we were able to stress the system, the gradient was not increasing. That means that the CVP is increasing as much as the mean systemic filling pressure. Unfortunately, looking at these subtle changes on a monitor just by looking at the CVP is very difficult. We need monitors that are able to look at cardiac output changes and see what happened bit to bit. But looking at this and try to understand what happened with that is not really easy. What I can do, though, is looking at cardiac output. And by looking at cardiac output, if the cardiac output increases and the CVP does not increase, that's probably telling me that the heart is working well. And if the cardiac output is not increasing and the CVP maybe increases a lot, that is telling me this is a patient that is not responding well to fluids. Now, what do we do in real life practice? Do we always measure cardiac output when we give fluids? Truth is that when we asked this question to many doctors around the world, we found out that actually the variable that is most used to evaluate a response to a fluid bolus is actually just blood pressure. So 70% of the times, clinicians just look at an increase in blood pressure to define if a patient is a responder or not. And of course, if the blood pressure increases when you give fluids, of course that patient had an increase in cardiac output. But what we know is that that relationship is not really maintained when you are in shock states and maybe you have noradrenaline running. So that relationship is not something that we can really follow. And it means that if I just look at mean arterial pressure changes, for instance, during a fluid bolus, well, I may be completely blind to patients that had an increase in cardiac output, but they sort of vasodilated a little bit, they redistribute that volume in terms of an increase in cardiac output, but the blood pressure does not change. So that's still a good effect because I'm probably recruiting microcirculation. I am increasing my cardiac output, I'm increasing the oxygen delivery. But by doing this, if I just look at the mean arterial pressure changes, I will not be able to spot this. And I may prevent some patients in which fluids are still beneficial to receive inappropriate therapy. So when we started to see all these conflicted results about fluid challenges and the practice that we found was very variable around the world, we thought, why don't we start from the very beginning? And we started to do some research thinking about the fluid challenge as a bolus of any other drug. So we started to think about pharmacodynamics of fluid challenges, and really we wanted to see what is the effect of a fluid bolus over time in our patients. So we took an approach very similar to the one that you would see by looking at the clinical effect of a drug. So we looked at the effect in terms of area under the curves, and we were interested to see what is the maximum effect of the fluid challenge, when do we see this maximum effect, what is the difference between responder and non-responder, and what happened after the peak of this effect. So we looked at the overall effect, we look at the maximum effect, and we look also at the effect after 10 minutes. So, as you see here, the area under the curve for cardiac output, obviously, if I define patient responders, by definition, they will have a higher cardiac output than the non-responder. There's nothing interesting in there. If you see the maximum effect happens about 1 minute after the end of my infusion. In this study, we use a fast, or relatively fast, fluid challenge technique. So we were giving about 250 mL of fluids in about 5 to 10 minutes. But if I see the maximum change is released within a minute. And why is that is important? Because if I go and drink a coffee and come back half an hour later, I may have missed completely this response. And why is that important? Because in a lot of patients, both in responders and in non-responders, we found that there was a redistribution of these fluids that was going back, maybe into the unstressed volume, maybe with some capillary leak, we don't know. But both responders and non-responders were decreasing the effect that we see at the very beginning. Now, I don't have the final answer about how to interpret this. This to me is posing more clinical and more research questions that we're trying to answer now. One possible explanation is that because we did this study in patients that were already resuscitated, so after the initial phase of stabilization, it is possible that these patients were not requiring extra cardiac output. So just by giving a fluid bolus, I was stressing the system, I was testing the Frank-Starling mechanism of this patient, but then the patient maybe does not need that cardiac output and just redistributes it back into the circulation. The other possible explanation that could be a bit more worry is that even in patients that are increasing generally their cardiac output, because they're in a state of shock, some of these patients may redistribute the fluids into the unstressed volume, and therefore the positive response that we see with a fluid challenge may be with a very, very short period. So what to do with this patient becomes very complex, because can we just carry on just by giving fluids to these responders, or at some point we need to think about what is the strategy, maybe to try to keep some of these fluids into the circulation, or to try to recruit stress volume, maybe with a tiny dose of vasopressor. We're doing some research of this. I don't have all the answers now. This is something that also other groups saw. For instance, this is a paper by the Brazilian group of Flavio Machado and Luciano Acevedo, and in which they were giving a large bolus of crystalloid, and as you see, very similar kinetics, a big increase at the beginning, but actually slowly going back to baseline after a few hours. Now, the variability is not just in the response that we see in the fluid challenges. The variability, when we asked around, was also in the amount of fluids that clinicians were giving at the bedside. Now, it is true that we were studying patients with very different conditions, but I can assure you, even from the same conditions, whether it was sepsis or cardiac surgery and so on, well, these patients were having very, very different amounts of volume that was given. We found anything between 200 mL to more than a liter. The rate was going from 5 minutes to 2 hours, and crystalloids were using 74% of the cases, colloids in the 26%. I suspect that if we repeat Fenice nowadays, and that was the time where all the starchy studies were coming out, the percentage of colloids would decrease even more. A question that I'm asked very often is, what is the dose of a fluid challenge? I think there are a lot of variables to take in consideration there. First of all, what do I define a positive response? Is a response a 10% increase in cardiac output, 15%, 20%? Depending on how I define my response, I may need a different dose of my drug to find and to be able to get the response. The rate of fluid administration, I suspect, plays a big role. There are not many studies out there that have been able to give us that answer about how can we standardize that. What we started to do was to keep the time fixed, and we looked at different doses of fluid challenges in 4 groups of patients. So we gave 1 milliliter per kilogram, 2 milliliters per kilogram, 3 and 4. And we measured changes in the mean systemic filling pressure pre and post these boluses. And then we looked at what happened in terms of responders and non-responders. So as you see here, giving 1 milliliter per kilogram in 5 minutes, we were not really successful in increasing significantly the mean systemic filling pressure. If I give 2 milliliters per kilogram in 5 minutes, there is a significant group of patients that will go above the threshold of our ability to detect a change. And 3 milliliters per kilogram, maybe some variability on the experiment, but again, it is there. It is only with 4 milliliters per kilogram that we were able to have in 95% of the cases a response that was able to go above the limits of the detectability of the mean systemic filling pressure. And what does it mean? It means that if I look at 1, 2, and 3, this is not enough to be completely sure that when I give fluids, if there is being a negative response, this response is truly a negative response, or simply I've not given enough fluids to the system. Why is this important? Because when we looked at the percentage of responders, we found a very linear relationship between the dose and the percentage of responders in this patient. We were actually a bit surprised to see the difference in magnitude between the 4 milliliters per kilogram and the 1 milliliter per kilogram, because we have no reasons to think that the baseline characteristics of these patients were different, and therefore the percentage of responders and non-responders would have been different. But as you see here, I would have probably missed a significant group of patients with this technique, which maybe could benefit from fluids if I want to give it. Now, after me, Jean-Louis Teboul will talk about the prediction of fluid responsiveness, and I agree with this concept. If we can avoid giving fluids, of course we should try to do that. But when we are faced with the idea that we have to try to give some fluids, I think it becomes very important to standardize how we do it, because otherwise we will not believe in the response, whether it is positive or negative. And I was telling you before, some other groups are working on other ideas, maybe thinking about using the time as the most important variable in the fluid challenge. So in this mini fluid challenge technique, they advocate that by giving 100 mL only very fast, so pushing the fluids, I think in less than a minute, they were able to predict fluid responsiveness with a good accuracy. We have done recently a meta-analysis on all studies that report fluid challenges technique in different fluid responsiveness studies, and we found again a huge variability. It's actually incredible that sometimes even the same research group uses different definitions of fluid responsiveness in terms of the increase in cardiac output or stroke volume. But we did find that there is a signal, significant, maybe it's not dramatic, but it is significant, in the sense that the fastest is the rate of administration, the higher is percentage of responders in our patients. So again, I think we need to do a bit more work, probably in the group of patients that we're studying, looking at the dose, looking at the response, and looking at the time that we use to define a fluid challenge. This was a study that Louis Forney presented before, so I will skip this quickly, but I do find it interesting that by using an approach in which we try to be a bit more conservative, even for organs which in the past we thought they are protected by giving fluids and by trying to increase the cardiac output, we found that even in this, for instance, the worsening of acute kidney injury was worse in the group that was receiving more fluids and not less fluids. Another study that caused a lot of attention recently was this study which was done, remember, in a resource-limited setting in which they tried an early resuscitation for septic shock clearly with hypotension, and in which they give a fluid bolus to adults with sepsis. What they found was the usual care, so no fluid boluses, was associated with a better survival compared to the sepsis protocol. Now, every time we see a study like this, we very quickly say, oh, fluids are very dangerous and so on. I think fluids can save a lot of lives. It's the amount of fluids, like for any drug, that can become a poison. And I think what happened here is, understandably, in a limited resource setting, you have to use a very pragmatic approach. What they found was that if I go didactically, just of giving maybe 20 or 30 milliliters per kilogram without seeing the response, after I trigger an initial fluid administration, maybe I can overload my patient. So the trigger is there. We all recognize that the patient is in shock. I suspect what these studies are telling us, if I don't measure the physiology, and unfortunately in some places it may be difficult to measure the physiology, if I just go very liberal on my strategies, I can start to see more risks rather than benefits in the things that they're doing. This is not telling me that fluid boluses are dangerous. This is telling me if there is no goal in what I'm doing, I'm blind, and by flying blind, maybe I can start to cause problem in my patients. As I was telling you before, we are very interested in doing research in this and try to standardize the technique a bit more. Why do I think this is important? Because if we do a fluid challenge, I believe we have to trust the response, whether it is positive or negative. If we don't trust the response, then there's no point of doing anything that we're doing there at the bedside. Now, we had a very interesting analysis in Fenice. In Fenice, we asked the clinicians, did you think that the patient had a positive response to fluids? And we didn't question whether that was the good response or a negative response. We didn't question any of that. We just allowed that judgment to the clinician. And then we asked if your patient, as the patient received a second fluid challenge after that. So a second fluid challenge was received in about 1,000 patients, which was 50% of our group of patients. So the interesting thing was that of this, 48% roughly were those patients that had an initial positive response. What does it mean? I have a patient that responded to fluids. The clinician thinks that the cardiac output has increased. Now, do you give an extra fluid challenge or not? We found 1 in 2 of these patients receive extra fluids. When we saw that, we were quite happy because we thought that's actually a good thing, because maybe the perfusion is improved, maybe the patient does not need fluids anymore. Just because it is a fluid responder, not necessarily we need to give more fluids. However, then we asked the question also to the people in which there was an uncertain response. So again, about 1 in 2 of these patients, they receive extra fluids. You may argue that's real life. We have a patient that is dying in front of our eyes. We gave some fluids. We are not so sure. Maybe we're not giving enough fluids. Let's give a bit more. But this was the striking data. 1 in 2 patients in which the clinician thought that there was no response at all and was sure about a negative response, still they receive some extra fluids. This to me is dangerous, but I can guarantee you, if I'm honest with myself, sometimes I've done this, I see this very often. The patient does not improve. We give fluids, FCV was just a little bit of water, and let's see what happens there. I think this can be very dangerous because we have a lot of data that shows that flooding our patient with fluids and provoking positive fluid balances is dangerous for them. I don't believe that any of the studies that will randomize patients to receive fixed doses of fluids will show any benefit. Probably they will show that we are causing harm because we will push the risk-benefit balance towards the bad things for our patients. And I think it's really tricky to do this if we don't have a physiological endpoint. I think what we should standardize is physiological endpoints, and then how we reach that physiological endpoint will be different for every patient. So we can standardize an approach, a system to identify how the patient requires fluids or not, but we cannot really standardize the dose for everyone. I think if we do that, we can cause some trouble. So to conclude, to me, it's not just how to give fluids, because we all give fluids. Let's face it, there's not a single patient that you've treated in your life that has not received a bit of fluid. The question really is how much is enough. So I think we need to start to think about fluids more as a drug, not because it's a fancy idea, but because they are a drug. And if they are a drug, they have benefits, but they can cause some trouble. I completely agree and have the same conclusion that Louis said. If I decide to give it, let's use a fluid challenge test. It's such a powerful way of doing it, just then running maintenance fluids, of opening the bag. It gives you a way to test the circulation, and at the same time, if it's necessary, you can feel the circulation. And I think we should give the minimum amount necessary to stress the circulation so that we get the maximum benefit, but if the patient is a non-responder, we've not given too much. Remember, there is an initial response, but there may be a difference in the sustainability of this response. I suspect we will do more studies in this. And also remember that different phases of the disease of our patient will require different strategies. Thank you.